Hello, I'm Dr. Roger Henderson. I'm a GP, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple, and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. In this episode, I'd like to talk about acute cholecystitis, or acute gallbladder inflammation, which is one of the major complications of cholelithiasis, or gallstones. Now, it develops in about 10% of patients who have symptomatic gallstones, with the gallstones obstructing the cystic duct, leading to bile stasis, gallbladder distension, and subsequent inflammation. The obstruction of the bile flow increases intraluminal pressure and leads to chemical irritation of the gallbladder wall. And this cascade results in a sterile inflammatory process, which can then become secondarily infected by enteric bacteria. The progressive inflammation can also lead to complications, including gallbladder necrosis, perforation, and pericholecystic abscess formation. Now, the initial phase of acute cholecystitis involves mucosal irritation and edema that progresses to transmural inflammation, vascular compromise, and potentially gangrenous changes if not promptly addressed. Now, in over 90% of cases, it's caused by complete cystic duct obstruction, typically due to an impacted gallstone in the gallbladder neck or cystic duct. But in around 5% or so of cases, bile inspission due to dehydration or bile stasis due to trauma or severe systemic illness can block the cystic duct, causing an acalculous cholecystitis. So the distribution and incidence of acute cholecystitis follow that of cholelithiasis because of the close relationship between the two. Epidemiologically, acute cholecystitis is more prevalent in women than men, particularly in those between the ages of 40 and 60. Our lifetime risk of developing gallstones is around 10 to 15% in developed countries, with a subset of these individuals then progressing to acute cholecystitis. Risk factors for the development of gallstones and cholecystitis include obesity, rapid weight loss, pregnancy, and familial predisposition. Additionally, patients with hemolytic diseases such as sickle are predisposed to pigment stone formation, which can also lead to cholecystitis. And metabolic syndrome, diabetes mellitus, and hyperlipidemia are also recognized contributors to gallstone formation. One really interesting point, I think, is that a recent meta-analysis has found that using glucagon-like peptide-1 receptor agonists, which are rather all the rage at the moment, are also associated with an increased risk of gallbladder or biliary diseases, especially when used at higher doses, for longer durations, and specifically for weight loss. So I think that's a nice point to remember if we're seeing patients on weight loss injectable medication who may now start to present with biliary problems. Now, as we've all seen in our patients, acute cholecystitis typically presents with right upper quadrant abdominal pain, with or without guarding, that may radiate to the right shoulder or into the back. And this is accompanied by fever, nausea, and vomiting. And this type of pain usually begins suddenly and is severe and steady. And any progression from biliary colic to acute cholecystitis usually involves a more prolonged duration of pain, often exceeding 6 hours or so. Physical examination may reveal a positive Murphy's sign, where the examiner's hand rests along the costal margin and deep inspiration causes pain. So just to remind us, lay 2 fingers over the right upper quadrant and ask your patient to breathe in. This causes pain and arrest of inspiration as the inflamed gallbladder impinges on your fingers. Now, do remember that a Murphy's sign is only positive if a similar approach in the left upper quadrant does not cause pain. That's sometimes forgotten. Now, this is a key diagnostic clue pointing towards gallbladder inflammation, but it does have its limitations, I think. It has a high sensitivity but a low specificity, and is particularly unreliable in older adults. So always elicit this physical sign gently, because it relies on causing the patient pain, and obviously this should be minimized whenever we can. And do remember to check for the presence of any jaundice too. Now, laboratory investigations often reveal a leukocytosis and an inflammatory response, shown typically by an elevated CRP and ESR. Liver function tests may be mildly elevated if there's associated biliary obstruction or inflammation involving the common bile duct, and bilirubin levels may also rise if cholelithiasis is present. I always suggest that amylase and lipase levels should be assessed to exclude pancreatitis, as this can coexist with gallbladder disease. Now, imaging studies, as we know, are absolutely pivotal in the diagnosis of acute cholecystitis, and ultrasound remains the first-line imaging modality due to its high sensitivity and specificity, easy accessibility, and lack of radiation exposure. Ultrasonographic findings may include gallbladder wall thickening greater than 3 millimeters, pericholecystic fluid, gallstones, and a sonographic Murphy's sign. An ultrasound can also detect sludge, as well as assessing gallbladder distension. Now, MRCP, or magnetic resonance cholangiopancreatography, can be performed if an ultrasound doesn't detect common bile duct stones, but if the bile duct is dilated or liver function results are abnormal. An endoscopic ultrasound may also be considered if an MRCP doesn't allow a diagnosis to be made, but this is obviously an invasive test and hence not a first-line one. Now, the Tokyo guidelines, which were developed to standardize the diagnosis and the management of acute cholecystitis, provide criteria based on clinical, laboratory, and imaging findings. And severity grading under these guidelines does help to determine the appropriate treatment strategy, and this ranges from conservative to urgent surgical management. So, in general, the management of acute cholecystitis includes supportive care, the administration of intravenous fluids, analgesia, and antibiotics that target enteric pathogens. Early cholecystectomy, preferably laparoscopic, is the definitive treatment for most patients and is generally recommended within 72 hours of the onset of symptoms in order to reduce the risk of any complications and to shorten any hospital stay. Now, NICE actually states that surgery should be performed within a week of diagnosis, where resources allow, but early cholecystectomy also appears to reduce the incidence of gallbladder gangrene and any potential conversion to open surgery. If we've got patients who are poor surgical candidates due to comorbid conditions, then a percutaneous cholecystostomy, where the gallbladder is drained using image-guided catheter placement, may be considered as a temporary measure. This can certainly stabilize critically ill patients and allows for a delayed cholecystectomy to be done when the patient's condition hopefully improves. Alternatively, Some patients may be managed non-operatively with antibiotics alone, although this does carry a significantly higher risk of recurrence. And it should always be remembered that gallbladder drainage, if undertaken, is not a permanent solution. And so whenever possible, a delayed cholecystectomy, usually 6 weeks or so after drainage, is recommended. Intraoperatively, the degree of inflammation and the presence of any complications such as empyema, gangrene or perforation can obviously be assessed. And surgeons do often encounter dense adhesions and distorted anatomy in severe cases, increasing the technical challenges with a laparoscopic cholecystectomy. So, conversion to laparoscopic to open cholecystectomy may sometimes be required in cases where there's extensive inflammation or unclear anatomy, where a critically clear view can't be obtained. Post-operatively, the care involves continued antibiotic therapy as indicated and monitoring for any potential complications, such as a bile leak, abscess formation, or retained common bile duct stones. An ERCP may be necessary post-operatively in cases where cholelithiasis is suspected. Looking at the complications of untreated or the delayed treatment in acute cholecystitis shows that these can be severe and include gallbladder gangrene, which can progress to perforation, and peritonitis, which, as we all know, is potentially life-threatening. Chronic cholecystitis may develop after recurrent episodes of acute inflammation, and this leads to a thickened, fibrotic gallbladder wall along with compromised function. These fibrotic changes can lead to a contracted gallbladder, which in turn may complicate surgical removal. Another serious complication is the formation of a cholecystoenteric fistula, where the inflamed gallbladder erodes into an adjacent portion of the gastrointestinal tract, potentially leading to gallstone ileus, mechanical bowel obstruction. The presence of any gallstone in the intestinal lumen, particularly the ileum, can precipitate obstruction that then requires surgical intervention. Now, at the top of this podcast, I briefly mentioned acalculous cholecystitis, a less common but more severe form of the disease that occurs in the absence of gallstones. And this is typically seen in critically ill patients, such as those with severe trauma, burns, sepsis, or those receiving total parenteral nutrition, and is also more prevalent in the elderly and the immunocompromised. Here, the clinical presentation may be less specific, with subtle signs such as fever, vague abdominal discomfort, or sepsis without any clear source. Now, diagnosing this is often challenging and relies heavily on imaging, with ultrasound and CT scans playing a key role here. Gallbladder wall thickening, pericholecystic fluid, and the absence of gallstones all raise suspicion for acalculous cholecystitis. And treatment generally involves broad-spectrum antibiotics and gallbladder drainage via percutaneous cholecystostomy, with cholecystectomy performed once the patient is stabilized. Now, fortunately, the long-term prognosis for patients with acute cholecystitis is good if timely and appropriate treatment is given. So, early cholecystectomy minimizes the risk of recurrent episodes and the development of any chronic complications. Mortality rates for acute cholecystitis are low in otherwise healthy individuals, but they can be significant in elderly patients or those with severe systemic illness, and if the gallbladder perforates, mortality is a significant 30%. Untreated acute acalculous cholecystitis is life-threatening and is associated with an up to 50 mortality. Preventive strategies for acute cholecystitis largely involve addressing the risk factors for the formation of gallstones. So this includes maintaining a healthy weight, gradual rather than rapid weight loss if appropriate, and dietary modifications such as reducing the intake of cholesterol and saturated fats, whilst at the same time increasing fibre intake. Ursodeoxycholic acid may reduce gallstone formation in high-risk patients, such as those with rapid weight loss from medication or after bariatric surgery, but this does have a relatively limited value in dissolving established gallstones, and so this is really best reserved for the occasional non-surgical candidate with small gallstones who is truly symptomatic. In specific populations, prophylactic cholecystectomy may also sometimes be considered, such as in patients with large gallstones, calcified gallbladders, sometimes called porcelain gallbladders, or those with non-functioning gallbladders at high risk for complications. Additionally, patients undergoing abdominal surgery for other reasons may have an incidental cholecystectomy performed if significant gallbladder disease is identified. One final point is that we should advise our patients that they do not need to avoid any particular food or drinks after having their gallbladder or gallstones removed. However, they should always consult us if eating or drinking causes any new symptoms to develop. So that's a quick overview of acute cholecystitis, and I hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We always love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.